we are going to get, I'm Christina Cottle. I'm the co-chair of the INSAR Student and Trainee Committee and the clinical intern at the University of Utah. Welcome to the INSAR Summer Institute. We are so excited to present our annual 6-week online series. This series is sponsored by the International Society for Autism Research and the Board of Directors. It is organized by the INSAR Student and Trainee Committee, and I just want to thank the Board of Directors for their support in this event, and then also the Student and Trainee Committee for the dedication to bring this series to life. It takes a lot of work. Just to briefly run through the Summer Institute series, the idea behind this was to provide an opportunity for early career researchers like graduate students and postdocs to learn about other areas of autism research and kind of get out of, find out different kind of areas. So in the past, we had kind of a broad overview of different aspects of autism research. Last year, we were focused on familial issues, and then this year, we're focused on culture and diversity. Partly how we come up with these topics is through your guys' feedback. So every year after the Summer Institute, we ask for feedback on topics for, coming years or ideas and stuff like that, things that you'll be interested in. And this year specifically was really brainstormed based on the feedback we got from you guys, so thank you. We're really excited to focus on culture and diversity this year. So I'm going to keep our intro really short today, just so we have time to really get to the speakers and everything. But I do encourage you to check out, the rest of our series. We have a great lineup. We have 4 speakers left after today, and I think you'll learn a lot from them. However, today, our first presentation is by Dr. Liz Pellicano and Ari Ne'eman. They are talking about ethics and participation in autism research. So before we get started, I want you to know that you can ask Dr. Pellicano questions at any time. What you'll do is if you look in the left-hand corner of the kind of web portal, you'll see a little chat box. You can send questions through that. We will be answering the questions on the back half of the session. So ask a question at any time. We'll grab it and we'll put it in kind of our own question section, and then we'll have a question and answer section at the end where Liz and Ari will answer any questions you guys have. We greatly, like I mentioned, we greatly appreciate feedback from attendees. So at the end of this session, take a few moments and let us know how your experience was. There will be a pop-up that asks you for comments. I'm really looking forward to hear what you have to say. There are also background materials for today's talk. If you haven't already, you can download these at autism-insar.org. These materials have like key terms and literature that you can look into as well that gives a little more information. So all of our Summer Institute sessions are created with our speakers, and then we also have a group of trainees that have worked with Dr. Pellicano and Ari to identify key journal articles and terms and goals for the session. And so we have some wonderful folks helping us do that. I want to take a minute to introduce them. Laura Graham-Holmes is a postdoctoral fellow at Children's Hospital of Philadelphia, and she is our INSAR Student and Trainee Committee member. She's the one who led our working group, so huge thank you to Laura for helping organize all of this. We also had Dr. Laura Crane. She's a Senior Teaching and Engagement Fellow at the Center for Research in Autism Education at University College London. She was our help from across the pond. And then we have Tanya Sang, a graduate student in developmental psychology at the University of California, Los Angeles. So Laura Holmes will be helping to introduce our speakers today and then also run our question and answer session. Just again, a huge thanks to our working group. You all did a wonderful job, and we're really excited to present to the presentation today. So Laura, I will turn it over to you so you can introduce our speakers.
Great. Thank you so much, Christina. We are really excited about our speakers today. So Dr. Pellicano is Professor of Autism Education and Director of the Center for Research in Autism and Education at University College London Institute of Education. She trained as an educational psychologist in Perth, Australia, where she also completed her PhD on the cognitive profile of children with autism before moving to the UK, to the University of Oxford, and then the University of Bristol. She became the director of CRAE in January 2013. Dr. Pellicano, one of the reasons we ask her here is that she's committed to understanding the distinctive opportunities and challenges faced by autistic children, young people, and adults, tracing their impact on everyday life, so at home, at school, and out in the community. She's also dedicated both to ensuring that the outcomes of her research are as influential as possible in education policymaking and to enhancing public understanding, including awareness of and acceptance of autism. So I think we would love to hear more about how she works those pieces into her research and into her career. Ari Ne'eman is the co-founder of the Autistic Self-Advocacy Network and served as its president from 2006 to 2016. He's currently the Chief Executive Officer of MySupport.com, an online platform designed to empower seniors and people with disabilities to self-direct their own services. In 2009, President Obama nominated Ari to the National Council on Disability, a federal agency charged with advising Congress and the President on disability policy issues. He was confirmed by the Senate in July 2010 and served until 2015, during which time he chaired the Council's Committee on Entitlements Policy. From 2010 to 2012, he served as a public mentor to the Interagency Autism Coordinating Committee, a federal advisory committee that coordinates all efforts within the Department of Health and Human Services concerning autism. So a huge job. Ari also served as an advisor to the DSM-5 Neurodevelopmental Disorders Work Group convened by the APA. He served as a member of the National Quality Forum's Work Group on measuring home and community-based services, quality, and the Department of Labor's Advocacy Committee on increasing competitive integrated employment of people with disabilities. So he's really done a lot in this country for people with disabilities. He previously served as vice chair of the New Jersey Adults with Autism Task Force, where he represented autistic adults in reviewing the state's autism services, and on the New Jersey Special Education Review Commission, where he authored a minority report on the topic of aversives, restraint, and seclusion. He's a board member of the American Association of People with Disabilities and the World Institute on Disabilities. He has a bachelor's degree from the University of Maryland, Baltimore County, where he studied political science in the Sondheim Public Affairs Scholars Program. So I will now turn it over to Dr. Pellicano and Ari Ne'eman for their talk entitled Ethics and Participation in Autism Research. Thanks so much for joining us, and welcome, Liz and Ari.
Thank you so much, Laura, and huge thanks to Christina, Laura, and Tony for organising all of this, and to Brooke for helping with some technological issues early on. It's a huge pleasure to be part of the INSAR Summit Institute, and especially to be able to talk about ethics and participatory autism research, a topic that lies close to both mine and Ari's hearts. And I'm even more delighted to be able to present this webinar together with my wonderful colleague Ari Ne'eman. We are going to take it in turns a bit at presenting, but here is what we'll focus on today. So first up, we're going to consider the kinds of autism research that gets done, and in particular, who gets to make those decisions. We will then talk about kind of a new way of doing autism science, autism research, one which we believe is more ethically informed, and that's participatory autism research. We will then move towards looking at kind of forming genuine partnerships with examples from community-based participatory autism research. And then the final part will be thinking about developing ways of working together, non-autistic people and autistic people. So just before we start, we have a note on language, that is how we talk about autism. The terminology, I think, that is usually used in research labs, in journal articles, in clinics, hospitals, schools, community, in the press, popular press, is what we call a person-first language. So calling someone a person with autism, describing what a person has, not what a person is. But many disabled people and autistic people have argued vehemently against the use of person-first language, instead preferring disability-first or identity-first language, such that he or she is an autistic person. And Jim Sinclair, who's an autistic activist, describes this beautifully here. So he says, autism isn't something a person has or a shell that a person is trapped inside. There's no normal child hidden behind the autism. Autism is a way of being. It is pervasive. It colours every experience, every sensation, perception, thought, emotion, and encounter, every aspect of existence. It is not possible to separate the autism from the person. And if it were possible, the person you'd have left would not be the same person you started with. And indeed, a wonderful autistic artist that we work with here in my centre, John Adams, once said to me, autism isn't something you have in your pocket, or you don't have in your pocket. That is, autistic people can never and should never be separated from their autism, both in life and in language. So throughout this talk, and in our work more broadly, we use identity-first language to respect the preferences of actually autistic people and their allies. And I think we would encourage you to think about the way in which you talk about autism, in your research, to your friends, to your family, to your colleagues, to your participants, and why you use those terms, and perhaps how you might want to talk about autism in the future. But that's a kind of cautionary note. Now on to the first issue, which is who gets to decide what gets researched in the field of autism. So let's start with the good news. In the past few decades, there's been a huge explosion in autism research. And this figure comes from a report on Autism Publications from the Interagency Autism Coordinating Committee through the National Institutes of Health in the US. And what I want you to focus on here is the blue line. I think I have an arrow that I can use. There's a blue line here. This one, that's what I want you to focus on, which is the number of autism-related publications. And so we've got the number of publications on this axis and time on the bottom, so 1980 to 2010. And if we look at 1980, we've got around 250 publications on autism being published around that time. And if we zoom forward to 2010, we have around 2,500 publications on autism. So there's been a massive growth, massive surge in publications on autism. And this growth far surpasses the growth of publications in similar journal categories. So now I want you to focus on the orange line, which represents the number of publications from related subject categories, which include psychiatry, pediatrics, developmental psychology, related categories where you might think that there might also be a surge in autism publications, but in publications generally. But in actual fact, there is a massive difference between what gets published in those fields and what gets published in the field of autism. So essentially, there's a lot of research going on, which, if put into practice, has the potential to transform the everyday lives of autistic people and their families. We know, however, that the opportunities and life chances for autistic people remain often severely limited in comparison with non-autistic people. So autistic people are less likely to have a well-paid job than non-autistic people, or even a job at all. Many also struggle with their physical, mental, emotional health, and also their material well-being. So that kind of, there's a lot of research going on, but, the opportunities and life chances are limited for autistic people, which raises the question, is the research that's going on actually making a difference to people's lives? And so to get our heads around why there might be such a mismatch between all the research that's going on and why autistic people and their families don't really feel as if much is getting better, a colleague of mine, Tony Charman, and I did a large study in the UK looking at what kind of research is going on. In particular, we looked at the amount of money that went towards autism research between the years of 2007 and 2011, so a 5-year period, and in particular what areas it was invested in for UK autism research. Now what you've got on your screens looks like a rather scary diagram, don't be scared. What I want you to focus on is are the hexagons, so the 6 hexagons. And this is the kind of classification system that we use to categorize the 106 funded projects that were done between 2007 and 2011 in the UK on autism. So we classified funded projects according to whether they were on diagnosis, so looking at diagnosis and screening tests, biomarkers, symptomatology, etc. Whether they were looking at biology, brain, and cognition, so from neural systems, molecular pathways, to kind of more cognitive work and sensory motor functions. Whether they looked at causes, and that could be genetic causes, environmental causes, the interaction between the two. Whether they looked at treatments and interventions, and this could include the whole gamut of treatments and interventions, from behavioural interventions to drug trials. Whether they looked at services for autistic people and their families, and this includes community services, school services, etc., but also looked at training for practitioners and professionals in the field. And then finally, we looked at whether the funded projects were on societal issues. And these could include things like social and ethical issues, biographical, ethnobiographical studies, studies looking at the cost or economics of autism, etc. So what we did was we categorized those 106 projects according to this classification system. And normally I get people to put up their hands to say which category you think attracts the most money, but I can't see any of you. So, but just spend a moment before I tell you, thinking about which category you think attracted the most money for research, autism research done in the UK between 2007 and 2011. So on what topic do you think that was the most money spent? Okay, I'm assuming you're thinking. This is what we found. So, as you can see, more than half of the UK grant expenditure between 2007 and 2011 went towards grants on understanding biology, brain and cognition. This totaled around £11.5 million across 60 different grants. But what I hope you can really see, if you add biology, brain and cognition and causes together, it means that more than 70% of the research done in the UK focuses on understanding the underlying biology and causes of autism. Only 5% of research, funded research, went towards understanding the most effective services for autistic people and their families, and only 1% went towards understanding the place of autism in society or societal issues. We also did the same for Autism Publications, and this is for Autism Publications in 2011. So we had some wonderful research assistants who classified those thousands of publications according to that classification system, and we get a very, very similar pattern. So research focused on understanding the underlying biology and causes of autism far surpasses research in other categories. And it's the same if you're in the UK, if you're a researcher in the UK, or in the US, or in Europe. Research on biology, brain and cognition gets prioritized above all other areas. I'm going to hand over now to my wonderful colleague, Ari.
Hello. Thank you so much, Liz. Pleasure to be presenting here with you. So this chart reflects research funding, autism research funding in the United States. It's produced by the Office of Autism Research Coordination for the most recent year in which the analysis has been conducted, 2013. OARC does annual analyses of autism research funding and breaks it down based on 7 strategic plan questions developed by the Interagency Autism Coordinating Committee. Generally, they run on about a 3-year delay. And one of the things you see reflected here is that generally we're talking about the same basic distribution of research funding in the United States and the United Kingdom. Very strong emphasis on causation and on biology, and very few investments in research on the needs of adults, referred to here as lifespan, which represents only 1% of the current American autism research agenda, and relatively little research on the needs, on the service needs of autistic people across the lifespan, representing only about 6% of the 2013 autism research agenda. So there are a couple of takeaways that we can have from that, a couple of major things that we should note. One that is not reflected in this chart is that if we look at the largest public funder of autism research, the National Institutes of Health, these numbers are actually even lower around lifespan and services strategic plan priorities. So a big part of the reason why we're seeing this significant gap is the fact that autism research around services and around autistic adults has not been prioritized by the United States' largest public funder, and similarly we see autism research around services and adults being insufficiently prioritized by the largest private funders. Where we tend to see more services research tends to be in the research agenda of the Department of Education, which maintains its own research funding arm in the United States, separate from NIH, and the Health Resources Services Administration, which also has some dedicated autism research funding. There are a couple of major assumptions that underlie this particular autism research agenda, which, while it's several years out of date, it's the most recent data we have, and it's actually held surprisingly constant over time. This is pretty much the same distribution of research, the few percentage points differences that we saw in 2012, in 2011, in 2010. We have not seen huge swings, at least in the priority areas that we're most concerned by. First, there's a long-standing perception in many parts of the autism world, and it bleeds over into the research community, that shows that presents autism as a recent phenomena or an epidemic. And that's not really what a considerable amount of research and evidence shows, which increasingly is causing many people, including those of us in the self-advocate community, to believe that autism is not a recent phenomena, but is in fact something that's always been with us, but is now increasingly being diagnosed to a greater degree than in the past, and identified in underserved populations like women and racial and ethnic minority groups. There's also a strong emphasis on the idea of the goal of autism intervention and treatment being a return to normalcy. And we see this in part because of the strong emphasis on biomedical interventions as the most effective means of improving quality of life. The fact that the autism research agenda generally prioritizes treatment over services suggests that for many researchers and for many research funding bodies, there's a perception that improvements in quality of life are more likely to come from biomedical interventions than they are from improvements in services and supports. And that's really inconsistent with a lot of what we currently know about autism. We have a fairly good idea how to target effective services and supports to autistic adults, to autistic children. We could stand to improve the structure of services and supports. We could stand to improve how we target services and supports for autistic people with the most significant functional impairments who may experience significant communication-related challenges, behavioral challenges, or co-occurring medical issues. But generally speaking, services and supports realize a fairly high return on investment when it comes to quality of life that just isn't reflected within the current distribution of autism research funding. And then similarly, the very small investment in research on the needs of autistic adults, again, presumes relatively few opportunities to improve quality of life in adults as compared to children. And while early intervention remains important and services to children remain very important, the sheer size of this disparity really should call into question whether or not we may be under-prioritizing the needs of autistic adults relative to the opportunities to improve quality of life and human dignity within that part of our community as compared to young children. A lot of this disparity in community priorities around autism research versus the actual distribution of research funding comes out of different models or ways of thinking about autism. And I want to highlight some of the differences in how different parts of the research community, certainly in how the self-advocate community as compared to the medical community tends to look at the autism spectrum. In general, when we talk about the medical community, and the research community often tends to follow the medical community's lead here, although not always, the underlying assumption is the medical model of autism. And the medical model of autism, like the medical model of disability in general, presumes that autistic traits, whether we're talking about lack of eye contact, repetitive behavior, focused interests, stimming, rocking back and forth, any number of other things, are themselves the inevitable sorts of challenges faced by autistic people. Under the medical model, there is a direct line between having an autistic trait and experiencing challenge as a result of that. And so when we talk about targeting interventions, we generally are talking about, under the medical model, targeting interventions to the same things that are looked at when undergoing a diagnostic process. The same things that you would look at to diagnose somebody on the autism spectrum are the things you would look at to determine whether or not an intervention is effective, and that's a big aspect in the research process. If you're asking yourself, is a particular treatment or intervention effective, the big question is effective to accomplish what? And under the medical model, generally the answer to that question is reducing the diagnostic traits of autism. And so very frequently in research that's utilizing the medical framework, the medical model of autism, the emphasis of that research is on the removal of autistic traits. The measure of treatment effectiveness is on the removal of autistic traits. And there is this implicit and sometimes explicit goal of recovery or making an autistic child or adult indistinguishable from peers. For self-advocates, and I would say also for a growing number of researchers, we are now seeing a shift towards what could be called the social model of autism, borrowing from the social model of disability that's been fairly well established in disability studies and disability rights circles for some time. And essentially, this introduces a new mediating factor between autistic traits and outcomes, be they positive or negative, faced by autistic people. And that's the context faced by autistic people. Autistic traits are what they are: a lack of eye contact, focused interest, repetitive behavior, sensory sensitivity, many other things. Autism is a very multidimensional diagnosis and disability. But these traits always have to be considered within the particular social context that a person may find himself in. Social norms in a local subculture or culture may significantly shift whether or not focused interests in a particular topic are an asset or a hindrance. Lack of eye contact may be heavily stigmatized, or it may simply not matter very much at all. Sensory sensitivity may present a very severe problem in some workplace environments or some educational environments, or with the availability of accommodations can be effectively not a significant issue. The availability of support services is a significant factor when we talk about some of the really more directly challenging co-occurring conditions associated with autism. For example, the availability of supported living services can help mitigate the independent living challenges associated with intellectual disability. It's a very common co-occurring condition within the context of the autism spectrum. And essentially, when we talk about the social model, anytime we're focusing on an outcome associated with autism, if it's a strength, if it's a challenge, if it's just a neutral difference, we have to consider the context before we try and relate it back to a specific autistic trait. And any effort to try and shift that outcome may well require focusing on the context rather than the trait. There are a number of other associations with the social model. First, the social model is generally associated with the neurodiversity movement, which is a term commonly used in the self-advocate community to refer to efforts to present autism as a disability and difference rather than a disease in need of cure, and really questioning the idea of a return to normalcy as the appropriate goal of autism research and intervention. As stated earlier, context matters tremendously in the social model of autism. The social model would suggest that we should be investing much more heavily in improving research on accommodations in educational settings, around shifting attitudinal barriers faced by autistic people, around improving access and the quality of service provision around things like residential, employment, and day services. Really critically here, the social model suggests that the measures we should be using when evaluating the effectiveness of a particular intervention should not be the same thing as the traits that we look for in determining a diagnosis. And the reason for that is we're abandoning the idea that the goal of autism intervention, the goal of autism research, services, treatment, whatever framework you want to use, is simply reducing diagnostic traits in order to make somebody look more or look less autistic and more neurotypical. But instead, we're focusing measures of treatment intervention on really more practical and person-centered goals. Like, for example, does a particular intervention improve the ability of somebody to be included in the general education classroom? Does it improve academic outcomes? Does it increase the likelihood of independent living or employment outcomes? And in many ways, that really tracks more directly the things that matter most to autistic people and our families. There are very few people who wake up in the morning and ask themselves, boy, you know, have they developed a new mouse model yet? Or, you know, how can I be more indistinguishable from my peers? Generally speaking, people wake up and ask themselves, how can I have more friends? How can I be more likely to keep a job? How can I be more likely to live independently? How can I be more likely to succeed in school? How can I pursue the kind of life I want? which, depending on the context one finds oneself in, may or may not relate to efforts to mask or mitigate autistic traits. I want to add one more thing when discussing the social model. Generally speaking, the distinction between the social and medical model is something that tends to be very different across different conditions. So, for example, there are many common co-occurring conditions that exist alongside the autism spectrum that autistic people frequently experience, where the medical model may be more appropriate to some degree or another. Generally speaking, when we're talking about epilepsy, reducing seizures is actually a fairly good metric of the effectiveness of treatments associated with epilepsy. And so when we're talking about at least some co-occurring conditions common to autistic people, a medical model approach may be more appropriate. Having said that, when we're talking about autism itself, as it's defined within the DSM and as it's understood by autistic people, generally speaking, we would say a shift towards a more social model approach would be appropriate and is something that really needs to occur and has yet to occur with the majority of researchers. So I'm just going to shift before handing things back over to Liz, just summarize a couple of the implications of these models for researchers. First, as many of you are well aware, there exist substantial political divides between parent and self-advocate groups on the direction of autism research funding. Many parent groups, and this has started to shift in recent years, especially over the last 5 years or so, when the self-advocate community has made significant strides politically, including in shifting the focus of autism policy conversations. But there still exists a significant divide between many parent and many self-advocate groups on the direction of autism research funding, with many parent groups still lining up behind the idea of a cure, and thus an emphasis on biomedical interventions and an emphasis on causation and biology in autism research, with self-advocates generally preferring to increase those long underfunded areas of research around services and around the needs of adults. And in addition, when we look at some of the research, and there hasn't been a lot, but we've seen some around the concept of autistic identity and the concept of neurodiversity and how people who both identify as autistic and have an awareness of the neurodiversity framework, the social model framework. Some of the things we see there is an increased likelihood of a positive identity around autism, an increased likelihood that one will oppose the search for a cure, and a preference for identity-first language, as Liz discussed earlier here, but association with the neurodiversity perspective and autistic identity does not reduce support for efforts to teach adaptive skills. And that's really important here because, again, it goes to the idea that when we talk about neurodiversity and when we talk about the social model, it's not a question of just abandoning people who are experiencing challenges and saying, oh, well, you know, we're going to say you don't have any problems and you're on your own. It's shifting from a model that says the goal of intervention is to make somebody normal to a model that instead says the goal of intervention is to pursue person-centered goals that actually relate to the things that are most likely to help someone achieve what they want for their life. And so that distinction between efforts to teach adaptive skills and efforts to cure or make indistinguishable from one's peers, autistic people, is really a very effective way of describing this distinction between social model and medical model thinking in autism research. Liz, back to you.
Thank you, Ari. That was a brilliant description of the kind of conceptual issues that we're dealing with. I'm going to follow that on with kind of taking you back to people's priorities around research. And Ari mentioned that there is this political divide between the parents and self-advocate groups. In this study in the UK, what we did is actually ask people directly what they wanted for research. So if you remember back, you might the scary diagram that I showed you with the hexagons, the 6 hexagons. Rather than show people that diagram, what we've done is break it down into 13 different questions, which I'll read through in a second. But essentially what we wanted to know was what people, so autistic people, family members, practitioners and researchers in the UK, what they wanted from autism research, and what they wanted the money to be spent on and why. So we gave them this online survey where they had to rate the relative importance of 13 questions, which could include things like how common is autism, to what extent is autism caused by environmental factors, what are the best ways to treat the core symptoms of autism, etc. And they had to rate these questions on a 5-point scale, ranging from 1, so that wouldn't be very important at all, to 5, which would be really important. And what I hope you can see from the mean ratings on the slide are that actually all of the questions were rated as relatively important by our respondents. That is, they approached kind of upper 3, 4 ratings. So suggesting, which I guess is unsurprising given that we don't know enough about autism, and that all of these issues were important to people. There were, however, a clear top 3, which included how do autistic people think and learn, how can public services best meet the needs of autistic people, and what are the best ways to improve the life skills of autistic people. There was remarkable agreement across the different groups, the 4 groups. So autistic people, parents of autistic children, practitioners, and even researchers who, as we know from our kind of initial survey, aren't necessarily doing research in those areas, they all rated these questions as their top 3. The only exception to this was that autistic adults rated the question, what does the future hold for autistic adults, rather highly, which again is unsurprising. And this is what we also did a lot of work with speaking to people in detail. So we did focus groups and semi-structured interviews with a whole range of people to kind of drill down and get a sense of why, what they feel about research and what they want. And this is what they said. So one 28-year-old autistic woman said, we need to know how to work with the services to make sure everyone has a chance of having a better life. A mother of an autistic child says, we need to understand the most effective ways to educate autistic children and provide life skills while respecting them as individuals. Another mother said, I want to understand more about how my child sees the world so I can better understand his response to it. And then a sister said, research needs to be carried out and put into ways to teach life skills and social rules to create more independence for adulthood. In our discussions with people during the focus groups and the semi-structured interviews, we found that it's not that people didn't value basic science research, so research on brains, cognition, genes. It's just that they wanted more research on those areas that affect the day-to-day lives of autistic people and their families. So research on public services, research on life skills, research on cognition and learning, and also the kind of place of autistic people in society. If you remember back from my initial scary diagram data, this is in stark contrast to what is actually being researched by autism researchers around the world. So what we're left with is this huge mismatch, as Ari said, between what is researched and what people want to be researched. So why is there a mismatch? Well, some autistic adults noted that the research being done represented neurotypical priorities regarding us, not autistic people's priorities. Others, particularly parents and practitioners, emphasized that the research failed to speak to the reality of their lives in the here and now. So one mother said in a focus group to me, said, you know, that's all that researchers are interested in. What causes it? What causes it? Doesn't say much for the kids that have already got it, does it? So one reason for the mismatch is different attitudes towards autism research, as Ari clearly outlined. So researchers are driven generally towards understanding causes, while autistic people and their families want research that focuses on more immediate, practical concerns. A related reason for the mismatch between what is researched and what the autistic community want researched is the lack of involvement in research by members of the autism and autistic communities. So as part of the research that we did for this project, we also asked about people's experiences of being involved in research, not just as participants or subjects in research, but actually involved in some way in the design, in the implementation of research, in the interpretation or dissemination of findings. So something around being involved in the research process. And what we found was that while the majority of researchers said that they frequently or very frequently engaged in public dissemination and dialogue or consultation with community members, actually only a minority of autistic people, family members and practitioners shared this view. So they didn't really feel that they were being engaged in any way. All groups of respondents, so that's autistic people, parents of autistic children, practitioners and researchers, agreed, however, that active research partnership or co-production of research was a rare occurrence. And I'll come back to that in a moment. When we asked them in more detail why there was this lack of community involvement in research, people talked about different attitudes, asymmetric interactions, and different priorities. So I've just got some quotes here just to illustrate these themes. So we've got one, the theme of different attitudes. One researcher says, the people making judgment about research and research funding have to be other scientists. One practitioner said, I don't think many researchers feel that they can talk to autistic people as if they matter. They're too busy studying them like specimens or looking for a cure. And then we have asymmetric interactions. So we had lots of parents in particular talk about, researchers are more keen on collecting data, not providing results. They really felt that they just give, so they give information about them or their child, and they didn't really receive anything in return. And the same went for autistic adults. So there was this real zoo metaphor that came across from our discussions with autistic adults. One of them said, sometimes we're a bit like monkeys in a zoo. They also talked about being like rats in a cage or guinea pigs. So really feeling quite, dehumanized by the research process. And finally, they talked about different priorities. So one parent said, most researchers operate from ivory towers with very little contact with real autism. In fact, this mother invited researchers back to spend a weekend with her two autistic children and her to get a sense of what it really, what it's really like to live and support people who are autistic. We also had a practitioner who said researchers are far too interested in causes and cures with intellectual understanding only and no practical application. Summing it up, one adult said to me in a focus group, rather skeptically, he said, whatever we say, whatever I say to you now, is it really going to influence anyone? So there's real feeling of disempowerment. And with this lack of involvement in research, a lack of involvement in the decision-making processes around research, it's not really surprising why there might be such a mismatch between what is currently researched on autism and what people actually want from research, how it's going to benefit, the kind of research that's going to benefit their everyday lives. Clearly, this needs to change. we need more research that actually matters to autistic people and their families, and will impact most on those, impact on those who need it most. And the way that we believe to do this is to make autism research more participatory in nature. So in other health-related fields of research, there's been a real push to involve kind of community members or so-called patients in the public in the research process. Beyond, being passive participants or subjects in the research, actually getting involved in, aspects of the research. It can be, the design, implementation, the analysis, the interpretation of the findings, the dissemination of the results, or all of those things. And the idea behind this is that if we get more people involved, so community members involved in research, we might actually deliver research that is more thoroughly relevant to patients and communities, that is sufficiently tailored to the realities of their everyday lives, and is consistent with their values. Now, participation itself can take many forms, and some of the forms are here, are described here. Contemporary models of community involvement have built upon Sherry Arnstein's ladder of citizen participation, which she described in 1969. Sherry Arnstein was interested in town planning, so nothing to do with autism, nothing to do with research, interested in town planning and how much citizens, everyday citizens, were involved or had some say in the decisions being made around the town planning processes. And so she developed this kind of ladder of participation, which has been used, and developed upon. So there are much more sophisticated models now, but this kind of gives you an idea. Where if we go up, this is the kind of would be the lower rungs of the ladder, where it kind of ranges from non-participation here. So really kind of things are being done to people. So in this case, assessing people or educating people. And as you move up, you get increasing levels of involvement or participation. So in this case, it's like informing, consulting, engaging. But with the idea here that this is, some of these things here could be tokenistic in nature. So for example, you might be involved in a research project that has an advisory group with stakeholders or community members, parents, autistic people, whoever, that, kind of advise you on various aspects, which would be great. But it's not so great if you don't actually take into account, what they say. So sometimes this is, the consulting aspect can actually be quite tokenistic in nature. And this is kind of referred to as kind of doing research or whatever for a group. As we move right up, we've got research or decision-making processes that are community-controlled or that are co-producing or co-designing. So the idea here is to increase the degree and nature of power and control by community members in decisions. And again, this can be about any decisions, but we're focused on research, so decisions in research. And so the idea is to get research that is carried out with or by community members rather than to, about, or for them. In my centre, I think we're somewhere in the middle, trying desperately to kind of move up into the darker purple bits up the top of the ladder. And we've recently done some really wonderful projects that have been co-produced by young autistic people on research that matters to them, which has been hugely rewarding. And again, I just have a think about where you are, where your research kind of sits within this kind of model, and importantly, where you want to be. So that's all fine in theory, but how do we actually go about involving the community in research? So together with an amazing group of autistic and non-autistic people, largely researchers, We held a series of seminars called the Shaping Autism Research Seminars. There'll be a link at the end of the presentation for you, which was funded by the UK's Economic and Social Research Council, where essentially we discussed precisely these issues. How do we get these things going? And to start, we kind of really felt that there needed to be a starting point. In particular, we came up with 3 initial principles of engagement or involvement, which I'll just talk through now. And the first principle is trust. So many autistic people and their allies who've taken part in autism research report a lack of trust regarding the research process. So the study that we did, really reported rather negative experiences from autistic people and their family members being involved in the research process, which as a researcher was really, really disheartening to hear. But that's their reality. Many told us that they, often give their time, their energy, their information to researchers, but receive nothing in return, never hearing anything about the results. And they feel disenfranchised by that. So we suggest that researchers, both autistic and non-autistic, must build up trust with the people with whom they are working. We need to be honest and committed in our interactions with people, saying what you mean and meaning what you say. So the kinds of things that you might want to think about would be, have you been honest and transparent about your research, so its goals and procedures? And obviously we all have to go through ethics applications and IRB protocols, and we ask people to read information letters and to sign consent forms. But are they, do they provide enough detail for people to really get a sense of what the research is, what they have to do, what the goals of the research are, so that they can make a proper judgment about them? Are the materials accessible enough for your participants? Have you told your participants about the outcomes of the research and how the information will be used? And importantly, have you taken, often we get feedback about, the research. So for example, we've done a survey recently, and one participant in the open kind of question at the end gave some comments about the research process, or particularly one of the questions and the wording that we had used. And we've obviously taken on board that person's perspective. So have you taken on constructive feedback from people being involved in your research? So that's trust, so building up trust. The second principle is mutual respect. So autistic people and their allies are happier with their experiences of contributing to research when they feel respected and their views have been valued by researchers, so both autistic and non-autistic. And as this quote clearly attests, the autism researchers that I have dealt with personally were always interested in what I had to say as well as my well-being. And here, we're kind of getting people to think about, are you treating your participants as people rather than just subjects or participants in your research? So you heard, some examples of autistic adults feeling rather dehumanized by the process, rats in a cage, animals in a zoo. We want people to feel like that they are valued. Have you made accommodations or adjustments so that they feel comfortable coming to your research lab or clinic? Have you asked participants views on your research at all different stages of the process or any stages of the process? Have you thought about how the research impacts upon those being researched? Not just the actual the test that you use or questions that you ask, but just the overall kind of aim and goals of your research. So that's mutual respect. And then the third and final principle is listening and learning. So researchers have expertise in designing and implementing research. That's what we're trained for. That's what we're good at. That's what we get paid for. Autistic adults have expertise gained from their lived experience of being autistic. Parents of autistic children have expertise regarding living with and supporting someone on the autism spectrum. And professionals have expertise regarding working with a range of autistic people on a daily basis. Some people even benefit from expertise in more than one of those areas. So you can have autistic researchers, autistic parents, parent researchers, or autistic researchers who are also parents. You can have a range of different expertise. And it's crucial for different kinds of expertise to be acknowledged and valued. By learning from other people's expertise, we can ensure that the research taking place is more relevant to those that it directly affects. So just to think about, do you think about the kind of benefits that an alternative type of expertise might bring to your research? Asking people about their experiences, their lived experiences of being autistic. How has your research changed, for example, following consultation or partnerships with autistic people and their allies? So it's all about it's not just listening to, it's also about learning from autistic people and their families. So these three principles should be our starting points for any research that we do with autistic people and their families. But we can and we should go deeper than this. And this is where I'll turn back to Ari for some examples of research partnerships.
Thank you so much, Liz, and thank you for a great overview. So we're going to talk a little bit now about some of the specific kinds of partnerships that bring together self-advocates and researchers in the autism context. And one of the areas in which this has been done very effectively is in the field of community-based participatory research, CBPR, which is a particular research model that essentially has traditional researchers researching within a particular community, whether we're talking about a racial or ethnic minority group, a disability community, any number of other variations, involving members of that community, typically through community-based organizations rooted in the community, as co-researchers and full partners in the research process. And the idea behind CBPR is to improve the quality of research, to make it more aligned with the values framework of a particular community, and to increase the number of useful insights and effective translation into practice that emerge from it by involving members of the community at every stage of the process, from topic selection to the collection of data, to the analysis of that data, to publication and dissemination. And CBPR, as well as its cousin, Participatory Action Research, which is just a broader category that has some less specific requirements than the CBPR framework, actually has a long history. It's been prioritized in the United States within the National Institutes of Health's National Institute on Minority Health and Health Disparities. There's been broad recognition that involving racial and ethnic minority groups as co-partners in the research process improves the quality of research within the context of health disparities experienced by those communities. More recently, the Affordable Care Act created the Patient-Centered Outcome Research Institute, which over the course of the last several years has been funding comparative effectiveness research in the United States and has significantly prioritized participatory action research models within that work, often explicitly participatory action research with the disability community. The Patient-Centered Outcome Research Institute, PCORI, has prioritized participatory action research within its funding priorities, has made significant investments, and really has looked at the involvement of self-advocates, patient groups, any number of other terms that you might use to describe groups of people with disabilities interested in engaging in the research process around their own diagnoses as full partners as part of its funding allocation decisions. I want to highlight one particular case study of participatory action and community-based participatory research, the Academic Autistic Spectrum Partnership in Research and Education, or ASPIRE for short, and you can check them out at aspire.org. I worked closely with ASPIRE during my time with the Autistic Self-Advocacy Network, ASAN. ASPIRE is really one of the leaders, I would say the leader, in participatory action research in the autism world. ASPIRE was started initially by both an autistic and a neurotypical co-director who continue to co-direct the project together and work collaboratively on all areas of ASPIRE's research work. It has partnered with ASAN and a variety of other self-advocacy organizations and community-based organizations to ensure that autistic people are represented not only as individuals, but as representatives from their community in their research process. And it includes a steering committee, a community council, and an academic council to help with the governance of the organization. Each project maintains the traditional structure of PIs and academic partners, but also brings community partners to bear and works through the organization's community council and steering committee to ensure the full participation of self-advocates within the research process. ASPIRE has actually managed a number of NIH-funded grants. It was initially funded by NIH to develop a toolkit of primary care resources for autistic adults and primary care providers. You can check that out at autismandhealth.org. Some of the interesting things about this toolkit, which again, having been developed through the participatory action research process, went through not only a process of review by traditional researchers and medical professionals, but was reviewed and edited in the same ways by self-advocates and community-based organizations, is that not only does it include resources on the healthcare access needs of autistic adults in primary care settings, it also includes a personalized accommodation report. Many autistic adults report that because of communication-related challenges, they have trouble making their accommodation needs clear to primary care providers. And so the toolkit includes a web-based accommodation report where autistic adults can answer questions about their preferred accommodation needs, and then have a report generated in language consistent with what a typical primary care provider could be expected to understand or respond well to, indicating how best to accommodate them in accessing healthcare. ASPIRE recently received another NIH grant to integrate the healthcare toolkit into 3 healthcare systems and evaluate results in primary care experiences of autistic adults as a result. And this is really something that the involvement of autistic people and self-advocates is absolutely critical for. The impact of having self-advocate input in the process when we're talking about people's experiences within healthcare settings is not something that can be replaced solely with a literature review or clinical experiences, because we are talking about the experiences of people with disabilities, of autistic adults ourselves within healthcare settings, and many of the challenges that we face, as well as many of the best solutions to address those challenges, cannot be fully understood by non-autistic researchers. I'm going to highlight a couple of things. Aspire has published on its work, both in terms of the object-level outcomes and some of the meta-level processes that emerged within the context of managing a research process with neurotypical researchers and some autistic researchers, but also autistic community partners. One of the things that was highlighted in particular was that often power imbalances exist between researchers and self-advocate partners that have to be addressed in order to allow for equality. For example, one thing that Aspire has done in some of its community council meetings is allow for participation, and in fact often have as the default for participation text-based communication, to reflect the fact that many autistic adults don't feel comfortable with phone and sometimes even with in-person settings. Aspire also manages community partnerships across the country, so in-person meetings are not always realistic, but phone meetings might serve as a significant barrier for autistic adults' full participation. And so the use of text-based and chat communication methods, while adding time for the research process, and it's very clear that community-based participatory research is often more time-consuming and requires investment of time and resources, resources being another critical component. Self-advocates participating in the research process should be fully compensated, and people should not be asked to volunteer their time for the production of research. In fact, Aspire has self-advocate employees, including an autistic co-director, and so that's an important aspect of this. We're not just talking about setting aside some funds for stipends. That may work at the community council level, but optimally, self-advocates will actually have staff time allocated to them too. So overall, the idea of addressing power imbalances is something that we need to make sure is optimized to the particular individuals and the particular disability communities that are interacting with the participatory action research process. For example, while self-advocates of one kind, say autistic adults, may prefer text-based chat communication, self-advocates with intellectual disabilities may vastly prefer phone conference calls or in-person meetings. And sometimes there can be challenges where conflicting accommodation needs emerge that require multiple or alternating means of supporting people to fully participate within the process and have a more equal relationship with the research partners. Some of the things Aspire has done within this context is develop a means of having all participants in the research process or on the research team communicate feedback that allows for gradations of approval or gradations of disapproval. Aspire uses a 5-finger system within their meetings, with 1 finger indicating enthusiastic approval, 2 fingers indicating somewhat less than enthusiastic approval, 3 fingers indicating being unsure, 4 less than enthusiastic disapproval, and 5 enthusiastic disapproval. This and other factors can help to allow for communication that takes into account the difficulty of some partners in adequately communicating the nuances of social communication. Often when working on a research team with autistic people, especially autistic people who are not professional researchers and may not have had access to these social norms of the research world, one of the most important things is to find ways to make some of the subtext of typical back and forth communication more explicit, to make the subtext text. And this again relates to the idea of equalizing the power dynamic between autistic and non-autistic partners. Finally, I want to highlight that CBPR and participatory action research as a whole is designed to involve autistic people throughout the research process, throughout every stage of the process. So it's not enough to just say, okay, we're going to hire some autistic participants to collect data, to act as interviewers, and we're going to call that participatory action research because autistic people had a job interviewing people for data on a topic that was selected by non-autistic researchers for findings that will be determined and analyzed by non-autistic researchers and disseminated. Optimally, the participatory action research process involves autistic people from the very beginning, the selection of a topic, potentially even the development of a grant proposal, through the design of a study, through the collection of data, through the analysis of that data, the drawing of conclusions, and any follow-up research that might occur. This, as a construct, is really designed to ensure that researchers must recognize the groups that they are researching as full partners in the process, and in doing so, have a much greater likelihood of producing research that is aligned with the values of their community, that is relevant to the community that they're serving, and that captures the insights that that community has to offer. So overall, we're just going to end here by noting that there is a significant gap between what autistic people and families of autistic people are reporting they want in autism research and what the current autism research agenda actually reflects. There's a significant need for researchers to be allies to the autistic community in shifting this gap. And as a whole, and Liz, you may want to say a few concluding words here too, we need your involvement in order to begin to welcome the autistic community as a full partner in the research process. Because at the end of the day, autism research exists to serve autistic people. And in the absence of that success, in the absence of that service, we are failing in our moral and ethical obligations to the autistic and autism communities.
I don't think I can put that any better, Ari. But just to say that, it is up to you, in particular, early career autism researchers. You are the future. You can change the way that we do autism research by genuinely involving autistic people in your research in such a way that it promotes, trusting relationships, is built on mutual respect, and involves listening to and learning from one another, which has been referred to as being empathetic researchers. Do you want to keep going, Ari?
No, I think we got it. Let's take some questions.
Okay. So I think that's done. Thank you very much. We've got a thank you slide, particularly to my colleagues. We've got a slide from Zoe. Do you want to say something about that, Ari? Or?
Well, this is a picture of Zoe Gross, the Director of Operations at ASAN. It reads, "I'm autistic, let me speak for myself." I believe it is a sign from one of ASAN's protests of Autism Speaks. Yeah, I think it just captures what we're trying to communicate here very perfectly.
All right.
Yeah,
well,
just a massive thank you.
We have a lot of great questions, I think, for both of you guys. So we will just jump right in. So Liz, you started the webinar by talking about the language we use to talk about autism. In some communities or organizations, there's still a big focus on person-first language, particularly when talking about someone's disability. The identity-first language is also picking up, but I've had the experience where I'm sort of emailing someone and I'm sort of not really sure quite which language to use. So how do you suggest both of you addressing people when you're not quite sure what they would prefer, or is it better to just sort of start with identity first and let people, tell you themselves what they would prefer?
Yeah, really
I think
good
it
question.
depends.
Thank you. Yeah, I'll go first, Larry. We did a recent, a large-scale project on this in the UK where we asked people, more than 3,400 people in the UK, how the kind of terms that they use to describe autism, so when they're describing themselves or their child or the people they work with. And we found that autistic adults and parents of autistic children preferred the term autistic, so identity first language. Most people seem to prefer the term on the autism spectrum. That was kind of a universal term that people liked. But as you suggest, there were a lot of practitioners who preferred person-first language rather than identity-first language. I guess my own view is that we should be using the terms that actually autistic people prefer, and really respecting their wishes. So I always use autistic identity-first language in the first instance. However, I do know autistic people who don't like that and who would prefer to be a person with autism. So I think on an individual level, I think you really need to ask where that's possible. Sometimes that's not possible. What how people would like to be preferred. But my suggestion from the research, but also from ethically, I think we should be referring to what autistic people want.
So I would agree with that. I think one of the important pieces of context here is that different communities' language preferences are heavily rooted in their history and in their particular experiences with the service provision system and with their disabilities. So the autistic community, and this is, by the way, also the case for identity-first language formulations in the deaf and the blind community, tends to prefer identity first in part because there's a long and very harmful history of service provision or treatment methods that are designed to separate autism from the individual and really often put autistic children and adults in the position of feeling like the way they move, the way they interact, the way we see and experience the world is inherently wrong, and that the goal for our lives should be to try and reveal some hidden non-autistic person within us. Within that construct, the person-first formulation that assumes that autism is something different from ourselves, that there is a non-autistic Ari hiding within the autistic Ari, is something that is really quite offensive and quite challenging. It really plays on that history. And so, when talking about the autistic community as a group, as distinct from any single individual's personal preferences, if you can ask people, by all means, ask an individual if you're talking about an individual. But when talking about the autistic community or the blind and the deaf community as a group, then using identity-first language is important. Now, having said that, people with intellectual disabilities have a very strong preference for person-first language. You should not take out of this that across the board you should only use identity first. The experience in the United States has been that people with intellectual disabilities, which I believe the UK equivalent term would be learning disabilities, what used to be referred to as mental retardation, are in fact feel quite strongly about the importance of person-first language in their own lives because of their personal experiences with dehumanization and depersonalization. And so there is not a single linguistic preference that will serve you for every disability community. Part of having cultural competency sufficient to work in a community is understanding that in an autistic context, identity first is preferred. An intellectual disability context, person first may be preferred, and so on and so forth.
Okay, thanks. So that's helpful to know sort of why this is so important and how much nuance there is when we're thinking about this. So we have some questions about what research should focus on. You mentioned research on psychopathology, like theory of mind, for example, in terms of investigating the causes of autism. And some people commented that this could actually fall under sort of understanding how autistic people think and perceive the world. Do you see a role for these kinds of research, either of you, so biological research, cognitive research, in improving services?
So I think it's a question of relative. I think it's a question of relative priority, right? So we clearly know that there's some role for biological research and research on etiology and the underlying mechanisms of action in autism. I don't think anybody is proposing, cutting all funding to those areas or anything of that nature. Now, having said that, the question of relative priority really matters when you're talking about a limited pot of research funds. We're not going to get to, the optimal distribution of research funding just by growing the pie, although that's something that I think we want to do, but there probably is some redistribution of priorities that will need to take place. And a situation where services research has been underfunded for such a long time, and we know there are significant returns on investment that can emerge from increasing funding to research on services and supports. So, my big takeaway here is it's not that there isn't a role for biology research or etiology research in helping to improve services. It's that given the significant underfunding of services research, both historically and at present, there's a need to shift the distribution of the research pie in some fairly dramatic ways in order to rationalize it with community priorities and with the areas of greatest possible return.
Thanks, Ari. And just to follow up on that, I mean, it is, it's right that there is, so say for example, I work on executive function in autism or executive function more broadly. So the ability, the umbrella term that describes the whole range of kind of processes that are important for everyday tasks. And there's a huge amount of research on executive function in autism, but remarkably little research that actually informs kind of interventions or tries to improve autistic children or young people or adults, planning abilities or ability to shift flexibly from one thing to the next. In fact, I can count the number of papers on one hand. So I think there is potential to ensure that more biological or cognitive work actually makes a difference or can be translated to better service provision, but I'm not sure that we've got there yet. I think researchers need to shift in that direction a bit more.
All right, great. So we had a question about writing psychological evaluations, people find that when they're writing evaluations or sort of clinical writing, they need to use a medical tone, as that's how providers, insurance, and organizations determine who needs services and what they need. So Liz, I know you worked as an educational psychologist, so you may have experience of this too when trying to ensure that people have access to the services they need and are entitled to in the classroom. Is there a way to bridge the gap between medical and social model when so many systems continue to rely on the medical model? Or did you find that you were able to do that in your clinical writing?
That's a very good question. Autism is a kind of a medical psychiatric diagnosis, and often, if not always, services rely on having a diagnosis, and therefore kind of fall in a kind of a medical remit. I think it's obviously there's a two-pronged or even more pronged approach here. One is a kind of top-down kind of approach where, we're not, we possibly can change the system, shifting kind of from a more medical model to a social model, but that will take time and a long time and a lot of effort. But I think we can do more kind of to change things from bottom up. So, for example, rather than thinking about, as Ari said, when he described the social model, rather than thinking about autistic traits and how we might change them or how we might focus on them in interventions, we might want to instead think about how we adjust the environment so that it's in the classroom that autistic children can be more ready to learn. So for sensory issues, for example, is a really good example. Rather than suggesting ways to make people see the world differently or more non-autistically, we can make suggestions around providing sensory toys or adjust the lighting in classrooms, adjusting noise levels where possible, those kinds of things. And I think we as practitioners or researchers have in our own individual as individuals, we can change those things and get people starting to think differently in schools and in communities and in research labs. So I think that there are some ways that we can do that while they're kind of hopefully they're pushing towards a more social model systemically.
Right. So that makes me think of That makes me think of a metaphor of, we provide things like wheelchair ramps for people who have mobility issues rather than expecting them to sort of start walking upstairs and things like that. So sort of working around people. Ari, did you have something that you wanted to add?
Yeah, well, first, I think the wheelchair ramp approach is consistent with social model thinking. That's actually the root of the social model of disability, talking about barriers of physical architecture and mitigating them. But it's worth noting that we've seen the kind of transition, at least in part, from medical model to social model thinking in a research context in the past. The intellectual and developmental disability community, including the intellectual and developmental disability research community, has a much stronger culture of social model thinking than we see in the autism context. So it's just important for us to understand that we're not waiting for some kind of unprecedented revolution in order to begin this sort of work. In reality, from the work that we've seen done successfully in the Down syndrome context, in the intellectual disability context, in the broader developmental disability context, there's a fairly long history of successfully supporting relatively robust acceptance of the social model in research and service contexts.
Right. So we have about, 10 more minutes for questions. So the one that I'm really interested in is a commentator had a question about sort of how to get research out to the autistic community. So I know that I sometimes find research through Facebook, through like Spectrum News or the Thinking Person's Guide to Autism. I'm curious about how, can you talk about whether you regularly look at research and how you sort of find that research, or how do we get our research out and make it sort of effective for people to consume?
Yeah, I mean, I think the autistic community in general is extremely interested in the research process and interested in research findings. One of the things that's noteworthy is that autistic adults have a fairly vibrant online community. There's an extremely active autistic blogosphere, and we're starting to see the emergence of some strong autistic-run media outlets like NOS Magazine, which is a catchy play on words, NOS, not otherwise specified. But I think clearest way of communicating with the autistic community is by reaching out through self-advocacy organizations. And there's a growing number, both in the United States, the UK, and internationally. We see groups like ASAN, like the Autistic Community of Israel, like the Pittsburgh Center for Autistic Advocacy, wide variety of others at the local, states, national, and international level. And generally speaking, if we're going to be talking about research as a partnership, and remember the CBPR PAR model includes dissemination as well as the actual traditional components of the research process, we should be building those kinds of funded partnerships with community-based organizations to disseminate research findings and data. So I would encourage you to look to connect with local self-advocacy organizations in your area or in your country of origin, and to formalize partnerships with them both for dissemination and for other components of the research process.
Do you have any advice on how to...
Can I answer that question too?
Yeah.
Sorry, no.
Oh, go ahead.
Yeah, can I? But just on a more practical level. So in my centre, our research team, we have a Facebook page, and in our team, each week a member of our team writes 3 to 4 kind of Facebook posts describing some autism research or some autism-related news during the week in an accessible way for kind of people who access our Facebook page. And I think that's a really nice, and that includes of course our own research and our own research findings. And I think it's a really nice way of getting our research out there and other people's research out there, but also practicing writing in a way that is accessible. Because, as researchers, we're not taught to do that at all. We're taught to write in a very jargonized, scientific way that isn't meaningful to so many people. And I think practicing that, and so we have we moderate ourselves in our own team, so everyone writes their posts and sends them around to people, and people change them to make them more accessible. And so we use it as a learning process to try and and to get our research across in the most accessible way. So that's just one example of what I think people can do, in their own kind of research labs about, to get their research out there.
That's great. Thank you so much. Liz, you described the political divides between parent and self-advocates groups on the direction of autism research funds. How do you propose that we bridge that divide? And, if there is a consensus, how do we promote that consensus to scientists to change their research priorities, or how should scientists, sort of balance this right now?
So in my experience, when we talk about how parents view autism, or really disability in general, that's heavily mediated by their experiences with professionals. And that's something we really saw very prominently in the American experience with both institutionalization and deinstitutionalization. Families didn't decide, we think it's a great idea to take our children with intellectual and developmental disabilities and put them in large state institutions. They were socialized into that perspective by professionals that told them that was, the only available option. And there was a significant experience of betrayal once it became clear that that was really not a good option for people, and professionals had led family members astray. And we've seen something very similar within the autism context. In many ways, some of the challenging views or emphasis on discredited causation theories, or belief that autism is a recent epidemic that we'll find some kind of magic pill cure for, is something that families have picked up from providers and researchers in their life. So one of the things I think we can do to bridge that gap is by thinking more critically about how the service provision system and how medical providers and how researchers communicate with families, because we do have a responsibility in helping family members develop a more healthy perspective on autism, and in doing so, put them in a position to better support their autistic children to grow up with a healthy sense of self-identity surrounding the autism spectrum. In terms of the political divides between parents and self-advocates, we're starting to see that shift. I think there's been a great deal more acceptance of the neurodiversity framework, both in general society, major American corporations now starting neurodiversity initiatives to recruit autistic adults into their workforce, but also within the parent community. The idea of not supporting a cure for autism was very revolutionary a decade ago. Today it's something that you'll hear many parents have the same views on as self-advocates. So, some of these divides are going to be addressed through the fullness of time. Until they are, and really even after they are, I would say researchers have an obligation to prioritize the views of autistic adults ourselves. That isn't to say to exclude family perspectives. Family members continue to have a very important role to play. They always will. But it's important for us to understand that family representation is not a substitute for representation of self-advocates, even when we're talking about researching the needs of children or people with significant communication-related challenges.
Right, so it sounds like there's really a need for us to figure out how do we sort of elicit the perspectives of children and those with significant communication challenges, so that we're sort of including everyone. I wanted to ask about community-based participatory research. So I think there's a sense that this is like wonderful and also takes more time and more resources, but is incredibly effective. What do you suggest for early career researchers like PhD students or postdoctoral researchers like most of us here who are interested in engaging in this kind of research and including autistic people in the research process but have limited time and resources and are sort of beholden to maybe the priorities of other people that we work for?
So some of that's a function of the responsibility. You go ahead, Liz.
Okay, that's fine. No, I was actually going to refer in part to what you mentioned earlier in your presentation, Ari. It does require, well, in some ways, more resources because academics get paid for doing autism research, but autistic people don't get paid for their experiential expertise. And so, to balance that, we really need to pay them. So, for early career researchers or PhD students, that's difficult because they often are doing it on very limited resources. We have just produced a starter pack for participatory autism research, which is specifically designed for early career researchers, but actually could be used by anybody, as part of our Shaping Autism Research seminar series, which gives some kind of, I think, quite nice, which was designed and developed with autistic people, practitioners and their families, and I think gives some nice kind of tips for and ways of going about doing or involving community members in the research that might not be so kind of resource heavy or time consuming. The actual starter pack isn't ready. It was meant to be ready by today. It's not ready by today, so it will be on our website on Monday. So I can send around. I can ask Laura maybe if you can send around or put on the website the link to that starter pack as a potential resource.
Oh yeah, I would love that.
I would just add to that many research funding bodies, including NIH, have prioritized CBPR, including resources to support self-advocates and to support researchers for the added time necessary to conduct participatory action or CBPR research within their funding priorities, including for early career researchers. So, there isn't necessarily a magic bullet here, but at the same time, when we're talking about the grant writing process, there are pools of funding that exist for this.
All right, so we should be seeking out, there's room for us to seek out those pools of funding and try to take advantage of those shifting priorities. I also want to mention something that John Elder Robison said at NSAR last year, which was that he said, as researchers, especially early career researchers, you're used to being sort of paid so little that you kind of pass that on to your participants and people who are consulting with you. So let's make sure that that you're paying everyone, fairly when you're asking for their time and expertise. So I think that's going to be our last question. I want to thank you so much for all of your wonderful expertise. I wish we could just kind of have a conversation for like another hour or something, maybe sometime in the future. That would be wonderful. So I am going to let Christina close up.
Thank you, everyone, so much. Laura, you did an awesome job moderating that. And Liz and Ari, that presentation was wonderful, and I think the session was fantastic as well. I think, like Laura said, that we could definitely continue this for much longer. I mentioned this last session, but one thought we're having for future Summer Institute webinars would be potentially having a stakeholder focused Summer Institute. So the whole summer would be focused on that. And so anyone who's listening, we'd love to hear feedback about whether or not you'd be interested as well. I'm personally biased because I'd be very interested in that, but we'd like to hear from you guys as well. I just want to thank everybody for attending today and providing wonderful questions. We were unfortunately unable to get to a lot of questions just because there were so many of them and the discussion was so rich. I'm going to talk to Liz and Ari about potentially answering these questions later on in like a Word document form, and then we potentially post them on the INSAR website. Several of the sessions have gone this way where we just don't get time to answer all the questions, and if it's possible, we might be doing that. So stay tuned. Continue to check in with the Summer Institute website for more updates. Again, I just want to thank Dr. Pellicano and Ari and the working group for this presentation. It was really a wonderful addition to the Summer Institute this year. Just so you all know, people who are listening, our video replays will be available on the INSAR website following the end of our Summer Institute session. So our last session is on the 24th of August. Following that, all of our videos will be available. That gives us time to edit them and post them. So please consider registering for other sessions as well. But it's beneficial to register and then pre-register and then go on later to look at the materials just so you have it. You get emails about it and everything. If you simply create a profile on the INSAR website to register for today, there are many more benefits if you choose to join INSAR. as a dues-paying member. You can become an INSAR member by visiting the membership page of the website. We really encourage you to do so. If you have questions or want to get more involved, you can contact the Student and Trainee Committee at studentcommittee@autism-insar.org. Again, that's studentcommittee@autism-insar.org. We really hope that you've enjoyed this session of the 2017 INSAR Summer Institute Series. Please take a few minutes to fill out the comment section. Once you end your session, you'll be prompted with a little quick survey. We'll also be sending out a survey at the end of the whole series, and we'd love your feedback. Again, this session and the whole Summer Institute series this year was really started with feedback from people who participated. Again, thank you everyone for participating and listening in today. Join us next week. On the 4th of August, we will have Dr. Roy Richard Grinker, who will be providing an anthropological view of autism research. He will also be talking about some of his work that he's done in various countries and really rural and remote places of the world. So we hope to see you next week. Thank you again for listening, and thank you, Ari and Liz, and our working group. Hope to see you all next week.
Thank you so much.
Thank you.
Thank you.